So it's my pleasure today to welcome Dr. Simon Wong from Vancouver, who I know does some outreach work as part of his practice. So welcome, Simon. Please feel free to introduce yourself and let us know a little bit about your practice and the kind of work that you do that is a little bit more in the outreach realm. I'd love to hear more about that.
Okay, great. Thanks, Gabby, for this opportunity to talk to you. Yeah, as you say, I'm Simon Wong. My practice is actually in New Westminster, so I'm in one of the suburbs in the Lower Mainland. But probably shortly after I graduated and completed my training, Dr. Alistair McLeod, who had been running an outreach program to Whitehorse, Yukon, invited me to participate as part of the rotation. I think he had, reached the point at that time to thinking about adjusting and scaling his practice. And I think with my prior role as a, general practitioner before returning to dermatology, he thought it may be a good fit. So I, accepted the invitation because I wanted to see what it's like to practice in a different setting. Because, during residency, we don't really have that much of an opportunity to be exposed to these kind of smaller communities and how life is. And I thought I would probably otherwise not go up to the Yukon for anything special, right? So it was a good opportunity for me to see a different part of the country. And yes, what was, I guess, initially going to be a trial worked out very well. And I've been doing this since, I think, about 2010.
Hmm. So what factors led you to do this kind of work rather than just focusing on your central practice, apart from what you've already explained?
Well, I mean, I think part of it is dermatology access is challenging to begin with. I mean, certainly we could just stay in our own center and just be very busy and not have anything else we need to do. But for me, it was an opportunity to just see how practice could be when you don't have necessarily access to all the testing, the labs, right? Some of the other specialists that may be readily available when you're in an urban center. Uh, I thought it would be interesting to see what it's like because I think it really challenges our ability to work on and help our patients. And as well, I think for patients, because it's harder to get in to see a specialist, I think you actually see slightly more advanced presentations. So it's a way to see and keep up to date, I think, on how to deal with uh, different dermatologic presentations.
Yeah, and that was leading into my next question about what you'd find unique about working in a rural community. You mentioned the presentations are really extreme, and of course there's lack of some of the subspecialty, auxiliary services. Anything else that you find very unique about going to the Yukon and working with this group?
Well, part of it is yes, in some ways, what the patients are willing to accept, right, in terms of how good or bad their condition is and how long it may take for them to improve, or they wait to say, okay, I guess I have to give this a little bit longer. But the other aspect that's interesting for me is because sometimes, even though Whitehorse is a rural center, because just the number of people, we actually service the entire Yukon territory and people from Dawson, from Oak Crow, Watson Lake, these are all smaller communities that are at least a minimum of 1 or 2 hour drive to get in. And Dawson is probably 5 or 6 hours. And for these patients to make the effort to come in and see us during our 4 to 5 clinics each year, it's also very interesting how they balance that. And then working with their own support teams that are there. So a lot of these centers really, they may have a physician fly in even as an outreach to those communities, or else they have a nurse practitioner, or in some cases just a nurse and maybe a pharmacy there to help support them. So I think it does change how I approach and even prescribe some of our advanced medications, right? We don't think about how easy or difficult it is for the medicines to get into to a patient's home when we live in a big center. And so it's just getting all of that and the logistics of getting the uh, all those different various factors in there together. It's
Yeah.
it's made me think about things I don't think I normally would have thought about.
Yeah, we take a lot of things for granted in the urban setting.
Yes.
That's for sure. So, I mean, based on your experiences after all these years, what do you find uniquely rewarding about working in the Yukon and in Whitehorse?
Well, it is exactly the fact that when we do get a I'll call it when we do get a win, right? When a patient does very well, it is very satisfying. That and the fact that I have built a lot of relationships with the practitioners in the area. Um, when I first started, they didn't know anybody up there. Now, realistically, whenever I go, it's almost like visiting friends that you haven't seen in a while. I usually have dinner or a lunch or something with some of the practitioners that have become closer friends. And so it's made that part very rewarding as well.
Some unique connections for sure.
Definitely,
Amazing.
definitely.
So, thinking about the challenges, you mentioned things like drug delivery and follow-up issues, but what are some unique challenges to working in this environment?
Well, some of it is even just turnaround for a lot of the labs and so forth.
Mm.
In a big center, you can almost expect most of our labs are either back same day if it's urgent or the day after. That's a little bit more challenging, and certainly not all labs are available. A lot of the requisitions that we have and the patients go and get any type of monitoring or imaging done, it tends to take a little bit because some of it has to be sent out. Uh, I mean, something even as straightforward as doing a KOH um, is the turnaround is a lot longer than what we would normally have. I mean, I have access to a microscope at the hospital, but even for that, it means I have to walk out of the clinic down the hall into the lab, and I have to borrow the microscope, and they're usually used for something else. And then for the actual culture to go out, and if I usually ask for a KOH as well, turn around locally in the lower mainland is maybe 24, 48 hours. For there, they have to send it into the lower mainland and then have it read and returned. So that typically means at least a 1 or 2 week turnaround. And since I'm only there for about a week at a time, we are
Mm.
dealing with things afterwards. So,
Right.
in some ways, it's been good with the pandemic that it's changed how a lot of the lab results and how we tell patients about things. So it's allowed for more virtual care, which I prefer to just a telephone call. Um, it's been pluses and minuses, I think, right?
Yeah, I think it's definitely helped us with people in remote areas. Certainly, it's been a nice adjunct to what we already do.
hmm
Absolutely. So when you have very complex cases in the Yukon, how do you manage those extremely complex cases that may need a higher level of care or other subspecialties?
Yeah, I close my eyes and I run away. I leave it for Kabir to deal with. That's why it's nice to
Hot
have a partner
potato.
go up. uh, I think we're very fortunate actually in Whitehorse. We do have access to rheumatology that is there, and as well for some of the other maybe less common services that we need. The We have access to both basically British Columbia and Alberta for backup. So because the a lot of the visiting specialists are drawn from either BC or Alberta, uh, it's not as difficult in some ways to access them. And when we do call, they do realize that hey, these are patients that are probably been really needing things done, but we've just been sitting because we've been trying other things as much as possible. The support is actually pretty quick from the other specialists.
That's nice to hear. Yeah, it can be difficult to reach out to those people, but once you have that web of relationships, right, like you say,
Mhm.
probably makes a lot easier. So these unique cases can be hard when they're very complex, but I'm just curious, what general supports do you think are lacking or could be better developed to do better work in a community like in the Yukon?
Well, I think over the years, we've definitely seen a change in the sense that obviously the change in primary care has been more challenging. And I think that's felt everywhere, whether it's in a remote community or in even the bigger centers. So we're certainly seeing that primary care is because they are swamped and not enough of them around. what used to be where we were functioning as consultants. So making recommendations and asking things to be followed and managed by locally by the physicians when they're there is now a little bit more difficult. Sometimes things that we are recommending, either the newer physicians in practice there now are not as comfortable, or the nurse practitioners, right, are not as comfortable, even though we try to lay out exactly what type of monitoring and how to deliver the medications. That's making it a little bit harder. So there's more of a pushback from primary care to say, well, we're swamped. Why can't you guys just order the labs and follow it remotely? And so it's a difficult thing for us, because I certainly see and understand why it would be tough for them, but then it's hard for us to, as the consultant now, to take on more of a primary care role in some ways when we've not had to do that before.
Yeah,
Uh,
the capacity becomes limited to
exactly. It's
meet.
where do you draw the line, right? Is the difficult thing. So I see it from both sides, and it's difficult to know what is the best solution. It's short of saying, hey, we're creating more people all of a sudden to in the workforce.
Yeah.
The other aspect is certainly, I think, not necessarily unique to a rural center, but it's on-call coverage. How do we balance when people are struggling with a more emergent issue, right? I mean, there are certainly provisions for transfer of life, limb, or organ-threatening things, um, but there is no specific contract or agreement between, say, the Lower Mainland hospitals with somebody in Whitehorse for dermatologic conditions. And again, it's difficult to ask people who are providing an on-call service to one center when another center who's no real agreement are calling and saying, hey, I need help.
Yeah.
Naturally, as we want to help, but at the same time, as the call volumes go up because physicians are not as comfortable, it becomes again, as where do you draw the line? How do you say yes or no? Um, I think
It's
Dr.
a
Dawa and
capacity
myself,
issue.
yeah,
Yeah,
yeah, we do our
exactly.
best. We do our best to say, hey, you can always call us, but
Hmm.
with so many physicians changing and clinicians changing, not everybody up there has our contact information. So again, it is a bit of a back and forth. I think we had talked about some of the on-call services, or not so much on-call, but these teleservices, right? The challenge with some of the teleservices for dermatology is, again, they don't really have access, and they don't know necessarily what the referring clinician's capabilities are. So a lot of times where it's, yes, so we agree this looks challenging and it should see the dermatologists when they're there urgently, we're stuck with, okay, well, everybody's kind of urgent right now. Where do we put these extra ones that it seems like it's out of the blue, right? And we don't have any information, and boom, you're expected to, because another consultant has said, oh, this is urgent. With really, I don't know how much responsibility they have if we can't deal with it. So does that mean it relies on us for being not available, versus they have quickly looked at it and washed their hands in some ways with the whole thing by passing it on?
Yeah, it comes down to a lot of volume and limited capacity and lack of agreements for who's
Hmm.
taking care of what piece. So thinking about a better system, what kind of incentives can you imagine, be they financial, educational, professional, or personal, that you think would encourage more specialists to choose rural opportunities for an outreach type clinic? What do you
Yeah,
think?
I think part of it is actually getting into contact with local medical associations. Even though I've been going up now for almost 15 years or so, I have to admit I have not thought about necessarily joining the Yukon Medical Association as a consultant. Not sure if we could, but I gather it's actually not an issue. And in looking into it, it's much like joining any of our local medical societies and medical associations. Yes, you have to pay dues for it, but you have access to some of the services as well. So it's reminding anybody who's planning on joining to say, hey, if you do that, you join the local chapter, they have access to things like CME funds, they have access to equipment purchase funds and so forth. So it may not be a bad thing to remind everybody about that. I have to admit, I've been remiss about being aware of that. And again, it's part of that sense of community that is probably more important than anything else. Because I think the financial aspect, it probably goes without saying, most of these very remote centers, the the um, the fee codes and so forth are designed to be very good. But at the same time, if you're not really living there and you're doing outreach type clinics, mainly because there's not necessarily enough people to support a full-time dermatologist, then really the amount of extra money you might make on being up there for a week, I don't know if that really adds that much, right? As a just a pure incentive alone.
Yeah,
Um,
I'm hearing that a lot. Ultimately, it's not really about the money. It's about a more well-rounded experience with lots of support. And I mean, certainly we don't want to lose money going to these places. It should be equivalent to the kind of work that we're doing in our own clinics. But it's ultimately about the relationships and the support you can gather while you're there to make the work more, to just to have the capacity to do the work well. Yeah.
mhm.
So
Yeah,
what
and
advice?
I almost think that it's if people are setting up, even though it may not, you may not see as many people per se, but certainly Dr. Dawal and I have found that if we're up there together at the same time, it's also a bit more enjoyable for us because we have each other we can bounce ideas off of, and at the same time, you can hang out afterwards if you are so inclined. So, I think you're right. That sense of community and finding ways to encourage the local community to reach out to the visiting specialists. I know the White Horse Group are very good about. For most of the specialists, they will usually have dinner with one or two of the people whenever they're up.
That's amazing. How nice. How welcoming.
Hmm.
What advice would you give a dermatology resident who's thinking of considering setting up practice or doing outreach work? What advice would you give somebody who's considering, that as part of their work in the future?
Well, I think a lot of what we've already spoken about, right? Make sure you're participating as part of the community, and I think that goes even if they're working in a larger center. Get out to know the local clinicians as your referral base. Try to make sure that you have a collegial working environment with the support persons and people. So making sure that people at the hospital, if you're at a hospital-based clinic, no one understand who you are. I mean, the lab's great. Whenever I walk by and say I need to use the microscope, they're all very excited and they want to see what I'm looking at. Uh, and get to know your local pharmacy. It is building that network. um, be prepared that yes, you may see things that are a little bit beyond what you would see, but that's what you've trained to be a specialist for. So you are equipped to deal with it, and then it's whatever your own local contacts you have, whom would you not necessarily reach out to, because we all have, whether we've been in practice for a short time or a very long time, we all have our little group of go-to people that have an extra insight into something that we may not have. And if you can have all of those things organized, whether you're working in a smaller center or a rural center, I think it should be no different.
Hmm. Yeah, true. That's great. So finally, how do you think the CDA could support rural and remote dermatology work in Canada? Any ideas?
Well, I think part of that is going to be helping us organize with our colleagues who run some of these telehealth services. I mean, they do definitely play a role, but how do we do it so that it doesn't feel like the group that are on the receiving end don't feel like they're being left holding the bag in some way, right? So again, it's a matter of collegiality and how do we organize the communications with each other. I think it would be totally fine if they say, hey, yeah, this looks like it may be something very important. But if there's just some way to let the people on the ground know, we do really think this is important because of these issues. But it could be that the patient being assessed, we already know them. And it may be they've blown us off for 5 or 6 sessions because they've just never been able to make it. But then we can maybe make the effort to figure out how do we get that patient seen in a different manner so that it's not such an urgent and look you have to deal with. Um, Other than that, I mean, I think the CDA has been good in continuing with education and providing patient support. So it's again letting them know that we're out there and we exist. I think in the smaller centers, we don't have as many issues with people who are not necessarily dermatologists, but they may just have an interest. Um, it's not that's less of a problem, I think.
Do you see a role for the CDA organizing people who do this kind of work together in a forum that could share ideas, experiences, recommendations? Do you think that would be useful?
Well, Gabby, any excuse for a party would be great, right? We just, we just invite everybody, and you have the residents there. They can talk to
Yeah,
us. Some of us who
love
do this type of stuff. I
it.
mean, I was very fortunate that there was already a lot of the infrastructure was already in place when Alistair had been there he had been going up, I think, for 20, 30 years already. So it was very easy for them to accept me in there. I mean, we're certainly still seeing some changes that could be made, and a lot of it is, I would love to get phototherapy back up in the Yukon and Whitehorse, but again, with a lot of the hospital-based things, we just lost out to having physio provide that support because their physiotherapy does it. But getting the unit replaced was not the problem. The problem was getting an FTE from the hospitals. So I
Mhm.
think if the association can help us navigate those types of conversations or teach us how, right, it
Mhm.
would be easy. We don't necessarily need the association to negotiate for us, but maybe if we heard from one area where they were successful in getting funding, we may be
Mhm.
able to utilize those same techniques at another site, right?
Not to reinvent the communication wheel over and over
Mm-hmm.
again. Worked well.
Exactly.
Love that. Well, thank you so much for your time, Simon. It's really interesting to hear about this kind of work that you do. I'm sure it's super interesting and very unique. And as I said, part of our conversation will be consolidated with other conversations to round out the kind of work that's being done nationally and to help with our advocacy efforts as well. So thank you very much for your time today.
Yeah, thanks, Gabby. Yeah, thanks for the opportunity to talk to you.